Okay, so herpes zoster. Have you guys ever got herpes zoster in your life?
Yes.
Anyone else? Oh, it's only one person. Okay. It was quite common, especially when you're young. We call it chicken pox. You've never got chicken pox? Wow, that's nice for you. I got it once when I was young. Yeah. So herpes zoster is an acute infectious viral disease. It is extremely painful and having insipidity. Sorry. It is extremely painful and having incapacitating nature. Okay. It is characterized by inflammation of the dorsal root ganglia or extramedullary cranial nerve ganglia associated with vesicular eruptions of the skin or mucous membrane in areas supplied by sensory nerves. I mean, this is a lot of stuff, but I'm going to explain. How chickenpox occurs is they usually have these vesicular eruptions on the skin. They are very itchy, very itchy. In fact, I feel people confuse the itchiness with pain. Okay, but they're very, very itchy and it can be very annoying. Okay. Then for this part, inflammation of the dorsal root ganglia, we're going to see when we're seeing the pathophysiology, and then supplied by sensory nerves. Basically, it occurs everywhere in the body, anywhere that is supplied by a sensory nerve. Okay, so look, so this is the trunk, as you can see here. And then this is the dorsal root ganglion. We know it enters the spinal cord. Initial infection with the virus, usually during childhood, causes chickenpox. The virus then moves to a dorsal root ganglion where it remains latent indefinitely. Remember when we did herpes simplex 1 and 2, we said how they go to the trigeminal ganglion and the sacral ganglion. So here we are going to a dorsal root ganglion. Then later, usually in adulthood, immune system depression or stress can trigger reactivation of the virus, causing shingles. So this is something I want you to remember. Primary infection usually causes chickenpox. Secondary or reactivation causes shingles. And then for one thing is, ideally in the primary phase, it usually affects almost all over in the skin. But for shingles, it's very specific to a dermatome. So for example, T10, okay, this person is at the back, but I can imagine the dermatome here is, considering T10 is at the umbilicus, and the umbilicus is somewhere here. So this is maybe T9. So reactivation will occur here, and the vesicles will be along the T9 dermatome. Okay? We're going to see a picture. So that is something I want you to know. For chickenpox, the primary infection, it affects throughout the whole skin. But for shingles, the reactivation, it follows a certain dermatome. Okay. Varicella-zoster is similar to herpes simplex virus in many aspects. Chickenpox presents the primary infection of varicella-zoster. Latency ensures and recurrence is possible as herpes zoster, as I had mentioned. Then varicella virus. So this is the skin surface. We have the hair shaft. Then the blisters form on the, this is the epidermis. So blisters develop resembling chickenpox and fill with pus. So they're usually purulent. Initial stage consists of burning pain and sensitive skin. So this is where you itch so much. It can be very, very, very annoying. Then what happens is this will end. The blisters eventually burst and crust over and heal. So they'll burst, then they'll crust over. You'll see, especially when you're seeing children, when they are healing from the chicken pox, it usually forms crust, like scabs, okay, all over the skin. Usually look like these black dots. Now, after that, what happens is the weakened immune system reawakens the virus. So when you get something like HIV, diabetes, you're taking chemotherapy drugs or you're taking immunosuppressant drugs, you'll have a weakened immune system. And what happens is you're going to reactivate this virus. So initially, this varicella virus was dormant in this nerve fiber. But now, when you get immunocompromised, what happens is it becomes reactivated, and then it will start following a certain dermatome. So let's say this is T8, it will follow this T8. So you'll have these blisters around T8 dermatome. The nerve damage can cause post-hepatic neuralgia. Yes, so this happens when during the primary infection, if the chicken pox comes and affects the nerve, it can cause post-hepatic neuralgia. So basically pain and loss of function of that nerve. Okay, so have you understood how the virus is usually latent in the nerve and then it becomes reactivated? So this disease is most common in adult life and affects male and female with equal frequency. Although rare, it does occur in children. So they're talking about shingles. The infection period is 10 to 21 days with an average of 15 days. So this is the herpes virus we had seen there. We know that it's DNA and icosahedral. Predisposing factors for reactivation. So the ones I was saying, we have HIV, cytotoxic or treatment with immunosuppressive drugs, radiation exposure, presence of malignancies. So malignancies are cancers, tumors, old age, alcohol abuse, especially when they say abuse, they mean that you've been an alcoholic. Stress can either be emotional and physical, then dental manipulation. So dental manipulation, why this is because what happens is when you do a dental procedure, let's say, for example, a root canal implant, we can have, remember I had mentioned the normal flora in the mouth. So the normal flora can leak, enter the blood, then you can have bacteremia. And when you're at a state of bacteremia, you become immunocompromised since you're having an infection. And when you're having an infection, remember your body is trying to fight off that bacteria, you become immunocompromised. And now the virus becomes reactivated. Then pathogenesis. After the initial infection with varicella-zoster, the chickenpox, the virus is transported up the sensory nerves and presumably establishes latency in dorsal spinal ganglia. Okay, note that. Usually the dorsal spinal ganglia. Similar eosinophilic intranuclear inclusion bodies indicative of viral infection occur in both the cases. Okay. Herpes zoster rash has healed. A debilitating complication known as post-hepatic neuralgia. So as I had explained, where you have loss of function in the area supplied by that nerve. The incidence and severity of herpes zoster and post-hepatic neuralgia increases with age in association with an age-related decline in cell-mediated immunity to varicella-zoster virus. Basically, what this point is saying is the older you are, the more likely you're going to get a severe form of herpes zoster reactivation. Then clinical features. So it usually has 3 phases. We have prodrome, acute, and chronic. During the initial viral replication, active ganglionitis develops with resultant neuronal necrosis, and severe neuralgia. So you have pain. Pain. It's usually the most frequent symptom and usually preceded by rash. So as the virus travels down the nerve, pain intensifies. It can be described as burning, tingling, itching, boring, prickly, or knife-like. So pain starts, the burning pain. And then after the pain, we expect the rash. So approximately 10% of affected individuals will exhibit no prodromal pain. But you can see 10% is a really low percentage. So most of the people will tell you, I'm feeling pain, itching pain, or a burning pain. So the pain may be sensitive teeth. So if it's sensitive teeth, you're looking at which nerve has been affected there, most likely the trigeminal. Otitis media, it can be pure nerve, so supplying the ear. Muscles of the ear, we have, it can either be the facial or the vestibulocochlear. Migraine headaches. So these are headaches that come and go, and they're usually pounding in nature. Okay, and they have aura. Basically, you feel, how I'd describe aura in migraines is you usually know when the headache is coming. You feel like flashing lights, tingling sensation. You have some weird feeling. That's what we call aura. And then myocardial infarction or appendicitis, depending upon which dermatome is affected. So myocardial infarction is what we call an MI. In basic principles you guys can understand is you feel as if you're having a heart attack. So that is if the dermatome affected is around T4, around the nipple area. And then appendicitis usually occurs on the right side of the abdomen. So around T8 to T10 dermatome. Okay, so that's how they'll describe the pain. Then zoster scene or shingles. This is how it looks like. What can you see here? This is the rash, as I had said. Can you see this rash? So you're going to be brought a picture like this in the exam, and they'll ask you, what is the virus? It's herpes zoster virus. Reason, look at the rash. It's very specific, and this is reactivated chickenpox. So it is following a dermatome. So I can't estimate this dermatome, but most likely it's T5 or T6, and it's following there. This is how it looks like. The pastern is called zoster scene or zoster with, it should be with the rash. So this is the rash. Sorry for that typo. The acute phase begins as the involved skin develops clusters of vesicles set on an erythematous base. Can you see these clusters of vesicles? Then at the base, you can see it's red. So that's what we call the erythematous base. Okay, clusters of vesicles and then a red base. Within 3 to 4 days, the vesicles become pustular and ulcerate, with crust developing after 7 to 10 days. So pustules, meaning they are raised above the skin surface, and then they become crusts. So as healing occurs, they start becoming crusts. Normally what usually happens is they become crusts and then they turn black and then they disappear. That's the phase of healing in shingles. Then we have oral lesions. So this is now dependent on the nerve involved. Oral lesions with trigeminal nerve involvement and may be present on the movable or bound mucosa. So remember, trigeminal nerve innervates the muscles of mastication, isn't it? And sensory touch to the face. Okay. So any sensation you feel on the face is innervated by the trigeminal nerve. So when the trigeminal nerve is affected, we said the most common symptom would be pain. So they'll be telling you, I'm feeling so much pain. The lesions often extend to the midline and frequently are present on conjunction with the involvement of skin overlying the affected quadrant. So what this means is, let me draw. This is your face. This is your eye. Then this is, let's say that's the middle. The lesions can extend like this. So let's say it's affecting here. Okay, so it's going to affect like this. And it extends to the midline. Normally it doesn't like cross over to the midline, but it extends somewhere there. Okay, remember it's following a certain dermatome. So if you can remember, the branches of the trigeminal usually have, the first one is ophthalmic branch, then maxillary, then mandibular. So if it's affected the maxillary part, you're going to have pain in that area. And then you can have the lesions. So the lesion can manifest as 1 to 4 millimeter white opaque vesicles that rupture to form shallow ulcerations. Okay. So here is a very good example. Look, this is found inside the mouth. These are the oral lesions. And then look at these. So this is the mandibular branch of the trigeminal nerve that has been affected. Can you see? So this is a very good example. The midline is somewhere here, if that was a straight line. So as you can see, it is extending to the midline. It's coming till here. As I said, normally it doesn't cross over, but it comes till there. Same to this, it comes, this is the midline. It's affected like this as it extends like this. This is the same pattern. So if you see this, you don't need to be told, you know that this is herpes zoster virus. Okay, then these are the oral lesions. Then involvement of the maxilla may be associated with devitalization of the teeth in the affected area. So there can also be involvement of the teeth. Several reports have documented significant bone necrosis with the loss of teeth in areas involved with herpes zoster. Okay, so you see the virus is affecting. It started the dermis, epidermis, went to the dermis until it went to it involves the bone. And when bone necrosis occurs, basically the bone is dying off because blood supply is not reaching the bone. And when that happens, you lose your teeth. Okay. It is postulated that the gnathic osteonecrosis may be secondary to damage of the blood vessels supplying the alveolar ridges of teeth, leading to focal ischemic necrosis. Basically, you can lose your teeth from that. Okay. Okay, good. Of the reported cases, there is almost an equal distribution between maxilla and mandible, with both sexes similarly. Ocular involvement is not usual and can be the source of significant morbidity, including permanent blindness. So this is another one. So here, what branch of the trigeminal nerve has been affected in this patient? Yes, who will tell me? Steve?
It is the ophthalmic.
The ophthalmic, good. So this is the ophthalmic branch that has been affected, as you can see here. This is the midline. We said it does usually cross over. It extends to here. So this one is a very specific sign. We call it the Hutchinson sign, okay? The Hutchinson sign of herpes zoster. So if you brought this patient, you'll know this patient, the lesions are not crossing over to the midline. Following a specific dermatome, you know that this is herpes zoster, okay? So we call it herpes zoster ophthalmicus or Hutchinson signs. And then these are the lesions, as you can see here, affecting this is the hard palate, okay? And then we have something called James Ramsey-Hunt syndrome. Also a manifestation of herpes zoster. Now for this one, what it usually affects is the ear, okay? A special form of zoster infection of the geniculate ganglion with the involvement of the external ear and oral mucosa has been termed Hunt syndrome. So Ramsay-Hunt syndrome, clinical manifestation, facial paralysis. So in these patients, you'll see facial droop, pain of external auditory meatus and pinna of the ear. Vesicular eruption occur in oral cavity and oropharynx with hoarseness, tinnitus, vertigo, and occasional otor disturbances. Okay, so what has happened here is the herpes has affected the facial nerve. And we know that the facial nerve gives branches. Facial nerve usually innervates the muscles of facial expression. So that's why we'll have the facial droop. Do you have a picture? Yes, this is a very good example. Yeah. Good. So can you guys tell me? This is the right. This is the left. What will I ask? Bernadette, which side has been affected? Is it the right side or the left side?
The left side.
The left side, good, because of this drooping. So here, herpes zoster has affected the facial nerve. How to know that is, number one, this is the nasolabial fold. If you see this side, it's usually lost in facial droop. Number two, normally, you know, your face usually kept in a tense state, not to droop. So you'll find this state it looks as if the face is tensed, but it's not. This is how the face should look. Then there's usually loss of wrinkles here. I mean, the face is blocking, but sorry, the hair is blocking the forehead, but usually there's loss of wrinkles. There's usually loss of these muscles are called what? Ocular muscles, not ocular muscles, sorry. The muscles surrounding the eye. So when you try and open this, you see the person can't even close the eye properly. Then when you try and open this eye with your finger, if you tell them to resist, it will be very easy, but on this side, it will be hard. Same to this. If you tell them to blow out their cheeks, air will be puffing out like this. But on this side, it will be okay. And then if you tell them to show you a kiss or to blow a kiss to you, what happens is the face will droop like this, so they won't be able to blow out a kiss. Okay? You tell them to smile, they cannot smile. This side will droop. So that's how you know involvement of the facial nerve. And then this is the ear. Remember, the facial nerve gives nerve supply to the ear, especially the stapes muscle. It's the stapedius muscle, which controls the movement of the stapes bone. So what happens is these people will have exaggerated hearing. So if you whisper on their ear, they'll feel a loud sound, because the function of the stapes bone innervated by the stapedius, by the facial nerve, is to dampen sound. So in these people, they're going to hear a very loud sound when you're talking on the affected side, on this side. Then oral manifestations. Okay, have we understood how Ramsay-Hunt syndrome occurs? Basically, it's herpes zoster affecting the facial nerve. So if you brought a picture like this, you're asked, what is the virus responsible for this presentation? The answer is herpes zoster. Then oral manifestations. Herpes zoster may involve the face by infection of the trigeminal nerve. This usually consists of unilateral involvement of the skin, areas supplied by either the ophthalmic, maxillary, or mandibular nerves. So lesions of the oral mucosa are fairly common. Extremely painful vesicles are found in the buccal mucosa, tongue, uvula, pharynx, and larynx, as we had seen. They generally rupture to leave areas of erosion, so it's very, very painful. One of the characteristic clinical findings of the disease involving the face and oral cavity is a unilaterally of the lesions. As I had said, it never crosses to the other side, but it approaches the midline. Typically, when large, the lesion will extend up to the midline and stop abruptly. Okay, so when it reaches the midline, stops, never crosses it. Histopathology, this is not really relevant, but we usually see something we call zinc cells. Okay, we call them zinc cells, which exhibit nuclear margination of chromatin and occasional multinucleation. But this you can never be asked, but that's good to know. Diagnosis. So we have viral culture, PCR, then this zinc test, where we see these zinc cells, but it's not even really done these days. A rapid diagnosis can be obtained through the use of direct staining of cytological smears with fluorescent monoclonal antibodies for varicella-zoster. So if you ask, just say PCR, dot blot hybridization, and yeah, culture. Treatment and prognosis. So for treatment, these people, they have fever. We give antipyretics that do not contain aspirin. So I'd like to hear your answers. Why do you think we don't give aspirin in patients with herpes? You guys can try. Why do you think we don't give aspirin? We can give paracetamol and these other antipyretics, you know. Who wants to try? Bernadette, do you want to try?
I'm actually not sure, but maybe because the fever is related not to other symptoms, but related. You said it spreads along the nerve roots and along dermatomes and all that. So aspirin does not directly affect nerves or something along those lines. I'm not sure.
I mean, that's a good trial. So so basically your point is aspirin is not used to treat neuropathic pain. So pain along the nerve root. That's what you're trying to say?
Yeah.
Oh yeah, I mean, that's a very good trial. Navia, what do you think?
Normally aspirin, isn't aspirin given to like thin the blood?
To thin the blood. Oh
It's
yeah.
a blood
Yeah,
thinner.
it also has, yeah, it's a blood thinner. It also has antiplatelet activity, but it's also used for pain. So yeah, but okay, that's I like your thinking. Steve?
I just think perhaps aspirin could exacerbate the inflammation which is there.
Okay. I mean, that's a good trial. So I feel like this is above your level, but you guys are going to learn. Have you reached painkillers in pharmacology yet?
No.
No, not yet. So it's okay, but that was a very good trial. So I'll tell you the answer. What happens is we never give aspirin to relieve fever. So in our instance here, we're talking about the fever. In people, normally children who have a viral infection, okay? You never give aspirin when treating a viral infection to relieve fever in children specifically, usually less than like 20 years old. The reason is we have a disease that it causes. It's called Rye syndrome. Okay. So I don't want to get into so many details, but what usually happens is you'll get something called hepatic encephalopathy, which is characteristic of Rye syndrome, basically liver damage due to the aspirin, because of giving aspirin when when lowering the temperature in a person who has a viral infection. So we give the other antipyretics. Okay, so antipyretics are fever-lowering agents. So if you want to take Panadol, that's okay. If you want to take paracetamol, that's okay. Ibuprofen, all of those are okay. Then antipruritic. So antipruritus means itching. So we have to give antipruritic medication, such as diphenhydramine. So this is an antihistamine, which can be administered to reduce the itching. Early therapy with appropriate antiviral medication, such as acyclovir, which has been found to accelerate healing of the cutaneous and mucosal lesions. So for the cutaneous lesions, we usually have something called topical acyclovir, where you just apply to the lesions and then they usually disappear. So let me write for you guys. It's called Rye syndrome. You can check it up in your free time and see what aspirin does. Okay. The medications are most effective initiated within 72 hours after development of the first vesicle, for higher chances of elimination of all those vesicles. On topical treatment, capsaicin has had significant success with 80% of patients. Who knows what capsaicin is? Have you heard of capsaicin? Who has heard of it? So capsaicin is the active ingredient found in chili. Who eats chili? This pepper, the green pepper and the red pepper. We call it pili pili, that one. You know it?
Like ho-ho, capsicum.
No, not capsicum. Chili, pili pili.
Oh, okay.
Yeah, the green and the red one. Those ones, the small ones.
Yeah.
Yeah. So that's it's not given, but it helps. As you can see, success in 80% of patients. Normally what happens is it binds to receptors on the skin. So remember, you're itching. So it's going to confuse your skin, because you know these things are hot. You've eaten, everyone has eaten chili here. These things are hot. So when you put it on the skin receptors are confused. So it will ignore the itching and now it will cause the pain. So that pain, it's not that painful, the pain that is caused by the neuralgia, but the pain will confuse your receptors on the skin to take away that sensation of itchiness. Okay? So that's why it's used. Then a live attenuated VZV vaccine has been approved for use of adults 60 years of age or older, since these people are immunocompromised and the incidence for reactivation is quite common. Zostavax is 14 times more potent than Varivax. Yes, thank you. And I'm done. Do you have any questions?